So welcome everyone to Sovereign Health, San Clemente. I'm Dr. Larry Snyder, the Medical Director for Sovereign Health. And before I present and introduce Dr. Dan Headrick, let me just say a few words about Sovereign. Many of you have been to these conferences each month, so I apologize for repetition. But we are now a three-program facility that is focusing, of course, on male dual diagnosis and female dual diagnosis, 2 separate homes, eating disorders, as well as mental health, with a residential treatment center in San Clemente focusing simply on mental health. Just in the last month, we have been licensed for residential and detox treatment for a male house in San Clemente on Paula, and also a female residential and detox house on Calle Real. In addition, we're developing outcome protocols for studying patients with depression and also chemical dependency, and expect to publish some data later this year on outcomes with regard to treatment, primarily brain wellness treatment, as well as the clinical treatment that we provide. So let me then please introduce Dr. Dan Headrick. It's my pleasure to introduce him. I've known him for several years now. Dr. Headrick is the medical director for the Pacific Coast Recovery Center in Laguna Beach at Mission Hospital. Prior to his taking over the reins at South Coast, or Mission Hospital now, he was at Hoag Hospital for 11 years as the medical director for their Chemical Dependency Unit. He has years of experience in this field and is a specialist in several areas of chemical dependency, but specifically in the treatment and the evaluation of pain with regard to opiate dependency. He has also appeared as the addiction specialist on many television talk shows, not the least of which was Real Sports with Bryant Gumbel. So it is my pleasure to introduce Dr. Dan Headrick as our speaker for April.
Thank you. I think you don't need this. Oh, yeah, that's right. Okay. Sounds like I'm hooked up. Okay, thanks. It's a pleasure to be here. We like Sovereign Health. We refer all of our difficult cases here. We know they're getting good care, and they're not paying me to say that. Am I getting paid for this? No. Yeah, we're going to be talking about chronic pain and addiction. It's a real interesting topic for me. I've been doing this addiction medicine for 26 years, and I've detoxed about 16,000 people in that time in the hospital. And I've had the unique opportunity and pleasure of being a full-time caregiver. Most doctors don't have that opportunity to stay in the hospital a lot. I'm there 8 or 10 or 12 hours sometimes a day. Most doctors come in and do rounds. They get a lot of information from the nurses that are full-time caregivers. And you just get a better feeling of what's going on, what this process of recovery is about, and what drugs really work and how they don't work, and the side effects. So it's been a real gift, and I have the best job, I think, than any other doctor. Although most doctors probably think I have the worst job. You work with those drug addicts all day, But we get to see people recover, and their families come in, and I get to see them, at the movie theaters or up in the ski slopes or out in the surf or and the family week, and we have a really good 30-day program and aftercare. So I was feeling pretty comfortable about 15 years ago. I got this down. I got addiction medicine down. I kind of can handle pretty much anything, and we're in a hospital, and we can take all the sick people, and it was pretty exciting. Then all of a sudden, about 12, 15 years ago, the people started showing up with chronic pain, and I didn't know what to do with them. In fact, at first, I was sending them back away. You need to go back to your your pain management clinic. They'd come in with terrible x-rays and CAT scans and surgeries and screws and pins all over, and massive doses of opiates and patches and fentanyl pumps in their spine, and I turned them away. But then what happened was I had some people refuse to leave, or they came back with their baggage and their whole family and saying, "You're going to take care of Mom here because Mom doesn't have a life," you know. And I realize now, looking back on it, it was pretty obvious. They didn't have a choice. They were trapped with the opiates. They were taking all these medicines and increasing them every year, and their pain was getting worse. And they had all these surgeries. And every specialist, 7 different specialists for 14 years, each one of them said, "Oh, you just have to take more opiates, or this type of opiate." And they knew that not only do they have their pain still, but everything hurts. And they don't have a life. They're constipated, they can't go to work, they're in ERs all the time, they're doctor shopping, they're depressed, there's no sex life. They can't get out of bed, you know. So when I heard those words, "I want my life back," that was really the determining factor that I thought, well, maybe we have a chance here. I almost don't even have to look at the x-rays when I hear that. They don't have a choice. They got to get off the opiates and unwind the system. And then I started reading about opiate-induced pain, which I didn't understand, and it really took a while to figure out, because it seems the opposite. Actually, what's happening is the opiates, after a while, can really cause pain. But it really makes sense when you think about it, because pain is really important to have. You can't really even live very long without the sensation of pain. There's been some studies of people born without very much sensation of pain. They really don't live very long. I mean, seriously, they could break something or have a wound somewhere and not know that they're supposed to take care of it and just keep walking on it, and they usually die before they're a teenager. So Mother Nature wired us in about 7 different ways to make sure pain stays intact. If you're giving your body a pill that says, "Don't feel pain, don't feel pain, don't feel pain," after about 3 or 4 months, and sometimes it's earlier than that, but easily everybody after 3 or 4 months, your body starts to feel uncomfortable and it wants to try to get back to normal. Basically, you could take somebody with 0 pain and put them on 4 months of OxyContin, and they'll start feeling pain more even before you start taking them off. And I started working with and bringing these people in, and I was really amazed that people could do what they could do when they had that motivation too. That's after studying the human body for all my life and stuff, I didn't think that after 14 or 20 years of taking opiates every single day that they can unwind this thing, get off the opiates, and the body recalibrates back to normal pretty quick. I mean, sometimes the Motrin starts to work even in a couple of weeks. And another thing we found out was it didn't really matter too much how much the opiate-induced part of this pain was. If it was 20% of the pain or if it was 80% of the pain, which it is frequently, either way, when you got them off and you got 20% or 80% of the pain off, when you unwind it, all the non-opiate things started to work. And there's a lot of really good ways to treat bad chronic pain with a non-opiate. But they don't really work too well when you're on the opiate. You've got to unwind the system and then do that. And so the things that we do to unwind that is pretty hard to do outside of a hospital. Because sometimes we're using 14 different medicines. Some of them are partially addictive, and then we're trying to wean them off those, and then all the other non-opiate type of therapies, and it's a pretty complicated system. So we started to take care of some people that were actually athletes too, professional athletes. They were in high contact sports. They were coming in. And the classic thing is, you know, football players gets injured and you should pull them out for the season, you know, and take care of it. But instead, they just get on opiates, finish through the season, and then at the end of the season, their injury is worse, and now they're addicted to the opiates. Now they have opiate-induced pain, and they're getting trapped. And because you don't want to leave in the middle of a season when you're making $5 million a year, they just power through it. So we started seeing these people getting addicted and chronic pain athletes. And I was doing some consulting for some TVs and radios and newspapers, and Brian Gumbel was his team, and he was calling up for information. He wanted to do a special on how many people are getting addicted in sports, professional athletes getting addicted. But I was trying to talk to him about, hey, you should learn about this opiate-induced pain. And he was pretty fascinated about it, and we were talking on the phone. And at one point, I was giving him a class like this on the phone. And at one point, he says, hey, you know what? We could do a story on this if you knew somebody famous. I was going, hey, what about me? I was going, what's wrong? And I did actually know somebody that's a pretty well-known football player at the time, and I said, he's in treatment. He's only a couple months sober. He's not going to go on national TV. But I went to the patient, and he said, yeah, I'll do it. So they flew their crew out, and for 3 days we were filming for 8-minute special. So maybe I'll show that first, because it kind of explains a lot in an entertaining way. Okay. I don't know if we can hit the lights.
It's a presentation of HBO Sports.
If it works better.
This is Real Sports with Brian Gumbel.
That an athlete's willingness or ability to play in pain has always been viewed as a badge of honor. That's common knowledge. But what's not common knowledge is how some athletes get addicted to the pain-killing drugs prescribed for them by team doctors. It's a problem experienced by a number of athletes, but revealed by a very few. In this Real Sports Illustrated report, Bernard Goldberg looks at just how powerful the grip of pain-killing drugs can be.
Let's just start off smoking crack. I'd stay up for 4 or 5 days at a time. Then eventually that didn't work for me anymore, so then that's when I started with the heroin. And combining the two was like kissing God. It was like, holy shit. I knew I was in trouble.
Before his life spiraled out of control, Jason Peter, all 6'5", 275 pounds of him, played on 3 national championship teams at the University of Nebraska.
Picked up by Jason Peter. Touchdown, Nebraska.
Was a $4 million first-round draft pick with the Carolina Panthers, and secretly was an addict. At the time, hooked not on the hard stuff, but on legal drugs that he says led him to crack and heroin. Drugs that are widely used among football players, prescription pain pills.
My relationship with the pills was I needed them more than I needed anybody in my life. I was married to those pills.
Normally, somebody might take, I'm told, 4 of these pills a day.
Yeah.
You were taking how many?
I was taking up to 80.
Sorry?
80
A day?
of the high potency, the strongest ones.
Do you get up in the morning and say, I have to have
I
my
have to,
painkiller?
yeah, I have to. I have to, otherwise you start getting the chills, you start sweating, you're going to go into, withdrawal.
You were a junkie.
Yeah.
Did you see yourself at the time as an addict?
No, it was pills. You get them from pharmacies.
What ended up as an 80 Vicodin-a-day habit started out innocently enough at Nebraska when Jason Peter hurt his knee as a freshman and went to the team trainer, who gave him another kind of pain pill.
He gave me Lorcets. I took 2 of them, and I was flying. It was a feeling that when it hit me, I was like, I want to feel like this forever.
You can't take it back like that, baby. I took it back for 6.
In college, Jason Peter says he took them every now and then, but it was when he got to the NFL, where players get hurt all the time, that he became addicted.
But when I was at the pro level, it turned into an everyday thing.
Every day you're taking painkillers?
Every day. It doesn't show up, on drug tests. It's part of the NFL.
You had no trouble getting these pills?
No.
Not from the team doctors, who were careful with what they would prescribe, but from other sources.
I meet doctors here and there at parties. They love having a jersey hanging on their wall or a helmet sitting on on their desk, a team ball.
And what do you get in exchange for them getting a helmet or a team ball?
Endless prescription.
And it's not just football players. Cody Payne says he got hooked on pain pills when he played basketball at the University of New Mexico.
I didn't realize how addictive they were. I didn't realize it was that bad.
Payne says he began taking Percocet, which was prescribed by a doctor after he had orthoscopic knee surgery, and was told by a coach that he better get well and fast.
I remember the day after my surgery, 7:30 in the morning, my knee's about as big around as a softball. I hear a banging on the door. It's the assistant coach. He came in just mad how it was his ass that he was worried about, and then, for me, I got, fuck you, Cody, just, we don't have time for injuries.
He said that.
He said that to me. That
We don't have time for.
we don't have time for injury.
Did that create some pressure on you? I better get better quick, and the quickest way to get better was with these painkillers.
Wouldn't have to. I mean, I think I'm the only option there.
For the record, the coach in question declined to talk to Real Sports, but did tell a local newspaper at the time that he's never told a guy who was hurt to play.
When did it occur to you that you're hooked on these things?
After the season was over, and I kept taking it. That's when it occurred to me, hey, something's wrong here.
But you didn't stop.
It gets to the point where you take them so long that you get scared to come off of them because you know you're going to be in pain coming off of them.
At one point, he says, he was so desperate to get pills that he even talked to his girlfriend about it.
She was a pharmacist. And,
Wait, hold on. Your girlfriend's a pharmacist.
Yes.
You didn't try to get her involved in it.
Yes, I did. And, she would not do it.
What was her reaction?
She could not believe that I would ask her to risk her freedom to give me some pain pills. And that was a girlfriend that I loved. And I still love that girl.
When that didn't work, Cody Payne risked his own freedom to get the pills.
I sold drugs to get more money to take pain pills.
What kind of drugs did you sell?
I ended up selling a little deal of methamphetamine and
To get money to buy more
to
painkillers.
buy more pain pills.
Did you get caught?
I got caught. It ended up being 2 first degrees and a 2nd degree felony.
Payne got 10 years probation, was through with basketball, and left school. And while nobody knows how many Cody Paynes or Jason Peters there are in the world of sports, in the world of pro football, prescription pain medications are just part of the game. What nobody knows for sure is how many players are secret addicts.
When you have an addiction, a problem like I had, it's nothing that you want to go public with. Am I the only one who used pain pills in the NFL? No. And I certainly have seen them in the locker room. You do what you got to do to be on that field.
The fact is, in many important ways, painkillers are miracle drugs. And without them, a lot of athletes would have been gone from the game a long time ago. But now, researchers have made a new discovery about painkillers. That if you take too many for too long, they not only stop killing the pain, but actually do the opposite. They create even more pain, and in places that never hurt before.
Pain pills cause pain. It was almost hard for me to even say that the first time I saw it and heard it and looked at the data.
Dr. Daniel Headrick is an addiction specialist in California who has treated dozens of professional athletes.
Your body's going to resist it if you start telling it not to feel pain. There's all sorts of systems that are going to kick in and say, no, you need to feel pain. After a while, you start having a body that's hypersensitive to pain.
Give me an example. What do they say? They say, I touch my hair and it hurts? I mean,
Oh, yeah.
well,
Yeah.
I just made that up. They say I touch my hair and it hurts?
Everything hurts. Their skin, their hair, every single bone. That's a real common complaint. Every bone in me, doc, hurts.
Every little thing. Every little thing.
Is that true?
I'll bang my thumb, and I'll think you'd have to amputate my arm.
It affected everything I did. Get in a car. I had to get in a car funny. Everything I did was painful.
And aside from creating more pain, sometimes there's another problem when it comes to popping too many of these pills. Doctors say they affect the brain in a way that makes you crave the kind of drugs you never even dreamed about taking before.
The use of pain pills opens up your craving center to anything. It triggers an attraction to alcohol and other drugs, speed, cocaine, even heroin.
Legitimate prescription painkillers can lead to a heroin addiction?
Exactly. Yeah. The brain doesn't know the difference.
Jason Peters says he didn't start on heroin until he left football, but was using some drugs like cocaine and ecstasy while he was still in the league.
The reason, I moved on to other drugs was because the pills didn't work for me anymore. I knew heroin was stronger. When I took those first 2 pills in college, that was the same way I felt when I started with the heroin and crack. And eventually, that didn't work for me anymore. I couldn't get out of bed. I was like a zombie. My eyes half open. No joy, no sadness, nothing.
Peter says he had finally hit rock bottom.
I went home to my parents' house. There was a lot of alcohol. I took about 60 or 70 of Vicodin.
At one time?
Over the course of about half an hour. And I swallowed about 20 of the Ambien sleeping pills. I wrote a letter. At that point, I did not want to live anymore.
He was out cold for hours. Even he doesn't know for how long, he says. And when he came to, he finally admitted he needed help. He's been in and out of rehab, and just 2 months ago, Jason Peter checked himself into another treatment center, this one in Newport Beach, California.
Recovery, trying to stop. It's the hardest thing I've ever had to do. And there's still times now, when I've been in treatment for 6 weeks, that I sit outside and I cry saying, I can't stop. I could easily jump this wall and be back out using dope and smoking crack again. That's how fucking tough this thing is.
Since he left the Panthers more than 2 years ago after a string of injuries, Peter says he often wonders what might have been.
What would my career been like if I didn't do the drugs? How much harm did that do to my body? What if I wasn't doing all that shit? Would my body have healed better? Would I still be playing now?
As for Cody Payne, he also went to rehab and says he hasn't touched pills or any drugs in over a year.
I've done a lot of things I regret, and that I hope I never do again, and I don't plan on doing again, but those things is the most powerful drug that I've ever taken.
It's miserable to have something run your life. And you're not going to get any better by sitting in your apartment, taking pill after pill, smoking crack, doing heroin. That's not the answer. If you want to live, if you want a life. I hope you make it. Thank you. I think I will this time.
Okay, thanks. I still have a resentment every time I watch that thing, because I didn't get a jersey, I detoxed them. These other guys write the scripts for opiates. They got jerseys, and plus I never got to say the F word, too. That would be kind of fun, but it wouldn't look too good with the white coat. But anyways, yeah, he wrote a book. He's really doing good. He was, we couldn't get him off the Subutex, actually, because he had a really bad anatomical, physiologic, he needed surgery. And so we got him down on some Subutex and everything else, and he had the surgery. He got on the real opiates for a while. Then we weaned him off that, and now he's doing fine. He's coaching high school football teams and stuff. He wants to get into radio. Well, he's doing radio announcing, and he wants to get into TV announcing, so you might see him. He got married and stuff, so wrote a book and stuff. So that's fun. This whole thing about opiate-induced pain has been really well documented, scientifically measured, anatomically measured, for over 12 or 13 years. But it's really not, I don't think, commonly accepted with the average doctor. I would say that about 80% of the really good doctors I know don't kind of really believe that it really is there, because it is unique. All the other drugs of addiction don't do this. Opiates will cause dependency and tolerance. That's different. Tolerance and withdrawals, that's all drugs do that. But this is about recalibrating how you experience and perceive pain. It's readjusting and magnifying the normal system into something that's pathologic. And I think part of the reason for doctors to accept this is because you took an oath to do no harm. And if you actually understand opiate-induced pain, you have to admit, like, you've been causing some of the pain. You know, I remember that first feeling. I went and saw the scientist that actually wrote the initial article. There was like 500 doctors, and most of them were anesthesiologists running pain clinics. And dual PowerPoint thing, and this guy's up there, and it's an amazing lecture. And when he finished, he was showing all the graphs and curves and all the anatomical changes in the spinal cord and the recalibration of the sensory nerves and the changes in the brain and stuff, opiate-induced pain. And when he finished, it was silent. There was usually there's some applause or something. 500 doctors, and the guy next to me looked at me and said, "You mean we've been causing pain?" And I went, "Yeah." And it kind of hurts because you're supposed to be perfect as a doctor, you know. So it's hard to sell, and it's one of those things. Another thing I found out too was a lot of the pain was emotional pain. We would unwind the physical pain and the opiate-induced part of the pain, and then the non-opiates would start treating the physical pain, and then all of a sudden there's all this emotional pain would start coming up, and then you realize that they were numbing their emotional pain, and we used to separate the patients that came in, and because we thought they were different, and they do have different tracks and stuff like that. And yeah, did you have a question? Yeah.
Briefly, since pain has become a vital sign, what did they report to you regarding their pain when you began to work with them?
That their pain is 9 or 10. Seriously, I've had people come in wheelchairs, 7 surgeries on the same spot in their back. You know, massive doses of opiates, morphine pumps in their spine. Turn off the pump, unwind the whole thing. People walk out in a month and they're taking Motrin. They're not even using their cane. Actually, you know, it's so amazing that I told myself when I do one of these lectures again, and I used to do it, I would bring a patient with me and just talk to the patient, because I think sometimes some of these things it's hard for me to even comprehend. You know. So we started to separate people and put in the chronic pain patients. So it kind of backfired. There wasn't as much honesty about where all this pain is coming. In the classic side, you know, we had a group in a room like this, and we'd have 6 or 8 people, and they're all chronic pain. Took their pain pills exactly the way they're supposed to. Didn't get any off the street. Massive doses. And we go, "Hey, how you feeling? Let's check in." "Well, yeah, and I took 14 Vicodin every day for 10 years, and well, I took 20 OxyContin every day for 20 years, and well, I had a morphine pump put in, I had fentanyl patches and 7 surgeries." It was almost like a contest. Felt like I was in pain, just being in the room with them. That's all they focused on. And there was a lot more honesty when we had the regular addicts in there. So when a gal sits there and says, "Well, I took 20 Vicodin every single day because my back was sore, you know, for 14 years," and then you have the heroines turn and they go, "I think that's bullshit. You don't take that much opiates because of sore back, you know." "Oh, well, I was raped when I was 14. "Oh, yeah, well, maybe that's it too, you know." And there was a lot more honesty when we just mixed everybody up, and all the all the addicts actually started realizing that they had all this numbing emotional pain too. And when you look at emotional pain versus physical pain, the potential of the intensity of emotional pain, I think, goes beyond physical pain. One way to measure that is, I've had some people commit suicide after 16,000 patients. None of them have been chronic physical pain. All of them have been something like a divorce, or they lost their job. Emotional pain is so intense, and they can't get a handle on it as much as a physical pain, and they feel more hopeless or something, and they just So everybody can relate to that. So we don't separate the groups that much. Another thing that I learned, these are kind of new concepts that I learned just 12 years ago. Chronic pain is not just a lot of accumulated acute pain. It's acute pain is actually healthy. It's physiologically normal. It's not a pathologic state. It hurts, but it's normal. It keeps you alive. You feel something, keeps you alive. Pain, ouch, works. Chronic pain is a physiologic imbalance. The nervous system, the spinal cord, different hormones have changed. It's a pathologic state. It's different physiology. That's why certain medicines that work for one don't work for the other one. Like, there's nothing better for acute pain than an opiate. It's perfect. It's the best thing. But for chronic pain, it starts to backfire in a lot of people. And there's really good medicines for chronic pain that are totally lousy for acute pain because it's different physiology. I had to get that straight in my head. Neuroplasticity is another word. Neuroplasticity really kind of didn't even exist when I went to medical school 35 years ago. It means like, a nerve can heal itself. And what I learned when I started out, 35 years ago, was like, you can't do that. It's permanent. Brain cell injury, it's permanent. And if you don't know that, you don't know anything. And it's completely wrong. It's a very fluid system. It's always healing and adapting and changing and remolding and recharging all the time. Which is good to know. Just for regular old addict, I always encourage or educate patients coming up that they're not going to have the same brain for the rest of their life. Actually, if that was true, I probably would find a different different field to practice in. People are really going to have their real brain back, but it takes 3 or 4 months, this project of brain healing, and some of it's for years. But it's good for people to know that. There's no such thing as a true pain fiber. I think that's deceiving, or it's misperception of really what's going on. Pain fibers, they're sensory nerves that have different specialties. There's like 7 main categories. There's some that pick up vibration or sharp pain or dull pain or heat and cold. There's different special sensory nerves, and they're picking up changes in your environment. And then those signals go through different channels and terminals along the spinal cord, and then it gets it in your brain. Your brain takes that in about 3 or 4 different places, and then it decides to call that information pain or not. That's how it works. But the sensory nerves here are incapable of creating the experience of pain. And I'll get into more examples of that. And another interesting thing is that the brain itself is numb. I don't know what that is. Kind of like this weird thing. I just like to bring it out there because it's kind of like, why is the avocado seed so big? Why did God do that? Anyways, your brain, when you cut into the brain, you don't have to numb it. Like neurosurgery, you have to numb the skull and the sac that the brain is in. But when you're actually cutting into the brain, you don't have to numb it. It's numb. But it's the only place where you can create the experience of pain. But it itself is numb. So if you can figure that out, tell me. Genetically, if people have addiction in their family or themselves and they have alcohol attraction, and then they're in a pain clinic, they really should be watched closer. Certain people get trapped a lot easier than others. Opiate-induced pain. Evidence-based medicine. That's like a criticism of addiction medicine that I frequently hear. Well, there's not. How do you tell? There's a group of people that you start, and then 4 months later, some are sober and some aren't. Why is that? Well, because some of them went to groups, and some of them had a spiritual experience, and some are exercising, and some of them did the 12 steps, and some are eating right, and it's not very exact science. So my criticism back to that is chronic pain treatment when you're giving somebody an opiate. Now, there's a lot of people that are taking opiates on maintenance dose, and they're not accelerating. I never see those people. They're out there. I hear about them. Or maybe they take weekends off and little breaks, and they never really recalibrate that well. And usually they don't have the genetics of addiction or alcoholism in their family or anything. But there's no evidence to justify chasing your pain with increasing doses of opiates. After about 3 or 4 months, and you're treating somebody with their pain, you're giving them opiates every day, and their pain starts to go up, and you try to chase it by increasing the opiates, you can do that for a while. But in the process, treating the pain, their quality of life goes down. If you start reading and looking at that and interviewing them, the constipation, there's no libido, they can't get out of bed, there's depression, they can't go to work, they're in ERs. The quality of life, all the studies show after about 4 months of opiates and you start to do this increasing game, you don't have any really good scientific justification of that. But a lot of people are doing that. So let me give you a couple examples of, well, maybe I should use this. I forgot we got this thing here. How the mind and the body works. Oh yeah. I wanted to do that. Okay. Okay. Let's try to do it. So. Has to warm up or something. How's this doing that? What's that? Did I push it too many times or what?
Turn around over, I think.
It's doing something. Can you just do it manually? No, I don't know. Oh well, that was. Okay, let me give you some examples of how your mind and your body work to create pain and how you get trapped. For broken toes, if we took x-rays of everybody in here, we'd probably find a couple people that had old fractured toes, and they might not even remember at all having hurt their toe. And it probably happened when they were 10 years old or something. And you spun out on your bike and you just put it back, and you didn't want to get in trouble, and you didn't want to waste your playtime, so you just powered through it and it didn't really hurt that much, you know. But that's a different experience if you break the same toe the exact same way and you're the place kicker for the Colts and you're making $5 million a year. That toe is going to hurt. You're going to see all sorts of specialists and get all sorts of therapy and treatments and x-rays and scans. It's going to change your whole life and your family's life and your whole profession because of that broken toe. It has different meaning to it. Shark bites. This is a study I didn't want to read because I'm in the water a fair amount. These scientists did this study asking people, what did it feel like when you got bit by the shark? And these are people who lost an arm and leg, not just a bite. Bad shark bites. What did it feel like? And most of them were from Australia. The most common response was, felt like a bump. Because it's not like TV when you're just sitting there and then you see the fin going around in circles and then it bites you. That would hurt the moment you got bit. If you saw that and did it, and it would be connected to your mind and your body. But you're just sitting there waiting for the next wave and it's nice and sunny and all of a sudden, boom, splash, crash, water's going all over the place. Seriously, there was some interviews and people were said they didn't feel the pain until they were on the beach, realized that there was blood all over, and then they felt the pain at that moment.
I hear pressure a lot.
What's that?
I hear pressure a lot.
Yeah.
I hear that, like a shark bite. I felt like just pressure.
Yeah.
I feel like pain. Pressure.
Yeah.
Were they in shock?
Yeah. But, I mean, they were conscious and stuff. But there was a sudden moment when they felt the pain, when there was absent, and they looked, and then they realized that it should hurt. Is it working now?
Yeah.
Oh, okay.
What do you want?
Oh, well, there's a shark down there. No. I guess, oh yeah, here we go. So, yeah, I worked through that. We were talking about oh, wow, you can touch this thing, huh? Okay. Broken toes, shark bites, colored words. Now, in the lab, they create pain by, and then they study you, but they put a little Velcro thing, it has 2 wires and goes to this battery pack thing, and the guy across from you is cranking up this thing, and he has this a scale that he's looking at, and you're just told to tell him when to stop. We want to find your pain threshold. It's just stop. And everybody has a pain threshold, and you can do it 15 times and land on the right side. Just, okay, stop, stop, stop. And so we find your pain threshold, and then we do different things, like they put a TV screen up in front of you, and it says the letters RED, but it's in bright blue, so you're supposed to say red. And then as soon as you say that, it's the letters green, but it's in bright red. And the faster you go, the faster it goes. And they say, oh yeah, tell us when it hurts. And they crank this up. Everybody goes past their pain threshold. 15 seconds ago you said, ouch, here. Now because you're doing this little game here, you went right past and said, ouch, there. So these nerves out here don't control the pain or create the pain. It's your brain. A joystick. This is another variation that they find your pain threshold, and then they bring in this box, and it has this joystick on it. And you're told that you can decrease the electrical current by pushing back on this joystick. So everybody does this thing, and the faster you push back, the more energy that's decreased on the electric. And everybody goes past their pain threshold. But the trick is the box has nothing, there's no wires, it's not attached to anything. It shouldn't have done anything. You're just sitting there moving this lever on this box thinking that it's decreasing the pain. You went past it. Hot and cold bars, that's not where you pick up people. This is the test they did on me. It's a coiled thing, it's thick metal, and it's got about 7 coils on it. And every other one is hot and cold. But you can put your hand on it, and that's hot and that's cold, but it doesn't hurt. And they say, roll up your sleeves, and they push it on your skin really fast. It really hurt. I thought they blew the test or something, or there was going to be a mark here or something. And they said, no, it's just hot and cold. Because what's happening is right here, there's some nerves that are sending up to your brain. It's pretty hot right here. And right next to it is saying it's pretty hot, pretty cold right here. And your brain takes that and goes, I'm out of here. That's pain. Move. Get out of here. That hurts. Do something. Phantom limb pain, that's a really crazy thing too. People have the pain. See, what's happening with phantom limb pain, and there's a lot of war injuries and messy kind of anatomical things to correct, and infections and poor circulation and surgeries, and eventually you say, well, we got to amputate after a couple of years maybe of chronic opiates too. But for a couple of years you're getting these pain signals that are going along these terminals, and what's happening too along the spinal cord, there's certain tracts that are in charge of pain. If you have this chronic pain going on, it widens and starts to recruit nerves alongside the tract in areas of the pain that never actually should be controlling pain. So you start adapting the spinal cord, almost like tattooing into the spinal cord the pain. So when you do the amputation, you still have this pain imprinted on your spinal cord. It's here, and people still, you say, where does it hurt? Draw a picture, and they draw a picture of their hand. It's not the stump either. I always used to think, oh, it must be the stump, and the nerves are doing something there. The stump is fine. It's just imprinted in the spinal cord, and that can unwind too. X-rays, you can't take a picture of pain. I used to think you could, but like a lot of people know what this is. This is a picture of a side view of a knee. This was done on a 65-year-old gal, and they were doing some studies on her foot, and they just did this scan on her knee, and they went back to her and said, hey, does your knee hurt? No, I don't even take Tylenol. It doesn't feel a thing. It looks like it should hurt. And then some people have normal x-rays, and they have a lot of pain, too. So we can't really rely too much on the x-rays as far as understanding their pain. Gender, they used to think that maybe a long time ago that it was even more sort of accepted, but not really written down black and white, that men can tolerate pain better than women. And I think it's because they do, most of these studies they do with the Velcro, and they're doing this guy. And that's how they test it. And guys go a little bit further. In fact, I was in a big lecture about 20 years ago, and a scientist was up there, and he was kind of implying that men could tolerate pain. It looked like they would go a little bit further than women when you do this type of test. And towards the end of his lecture, a woman doctor stood up and said, I don't think that really shows that pain, men can tolerate pain better. I think it shows that women are smarter. They're more in touch with their feelings, and they're not going to go there. Why not stop here? And it kind of blew his whole lecture. But they have done the other studies, and recently this is a real classic, easy test to do. They get a guy in there, and a guy is testing you. Find your pain threshold. The tester guy leaves. This good-looking woman sits there and does your test for you. And they say, tell us when it hurts. You can't see the gauge. Every guy goes past it. You're looking at this woman that's like 3 feet in front of you. Every guy will go past it a little bit. Some people go way past it. They think they're doing it in the same spot. So there's the macho factor in there too. Let's see. Well, yeah, I didn't really get in that. We have a whole protocol to use Suboxone, Subutex, buprenorphine is a really nice medicine that's helped us back out of this. It's a partial opiate and partial anti-opiate, and it really helps us out a lot. TENS units, Motrin, SSRIs, the older Elavil, the older antidepressants too, anticonvulsants, even Lyrica, Neurontin and things, muscle relaxants, we throw those in, Robaxin, lidocaine patches, acupuncture, heat, ice, TENS units, everything. Sometimes 14 different things. Actually, the first thing is giving people hope. And I don't know where that one is. But anyways, giving people hope, because most people have the opposite. They've been given or created in them by going to all these different specialists, and every one of them says, well, you just need to take more of an opiate. They know that's not working. So when they reach this end point where they're taking massive doses of opiates, they don't think there's any other, they're trapped. There's no way out. And when you start describing it to them what the trap looks like and how to unwind it, sometimes you can feel like 20% of the pain goes away just when you give them hope. And I gave the, let's see. Whenever I get somebody that actually makes that big transition, like seriously in a wheelchair, and they come back and they're walking without a cane, they're taking Motrin, I always grab them and say, how did you think this worked? What, in your mind, what was the most important thing? How did you make this possible? And the most common response, and I thought it would be something like, it's something you said, Dr. Headrick, but it's not. Yoga. Yoga? That's what really works for you? Yeah. I thought we put that on our website just to make it look better. Yoga is something that's a real powerful thing that empowers the patient. They do it to themselves. You're not doing it to them. I used to think acupuncture was going to be the big thing, and it is pretty good. It's really good actually for detox symptoms and stuff, and there's ear points, and it really helps that phase. But for chronic pain and unwinding this and giving somebody empowering, it actually does the opposite. It almost makes you feel like you're the weak person. We're doing this to you, and then they have to make arrangements. You can't do it as when you leave and you pay for it. Yoga is something you do for free. You do it yourself. You learn how to do it. And people say, yeah, I went to this class, and I was like only 3 days into my detox. And in the first class, I felt 20% of my pain go away for like 3 minutes. The first class. And that really gets their attention. If you can do that the very first class, and then they keep going 3 or 4 times a week, they really get good at decreasing the amount of pain they feel just by form of meditating, yoga, breathing, all that. But some of it too, is living with it too. Sometimes we can't get rid of all the pain. And that acceptance that there's going to be like 10 or maybe even 20% of the pain that you're going to have to accept is really hard for certain people. And I gave this lecture. The society's really changed. I gave this lecture to a group of doctors, and an 85-year-old retired doctor came up to me and said, I practiced family practice right here in Orange County for 50 years. I never prescribed an opiate. There was like 5 or 6 people that I prescribed Darvocet for. I go, how did you do that? And then I remembered too, 30 years ago when I started family practice out in Lake Elsinore, you didn't really have to write that many opiates. The classic person that had trauma was in the hospital, had some surgery, the orthopods did that, and then the surgeon would send them out on discharge with 2 weeks of Vicodin, and then it was our job to fix that patient and get them on all the non-opiates and do the physical therapy and the heat and ice and ACE wraps and all that stuff, and Motrin and Tylenol, whatever worked. You didn't really have to. In fact, I'm thinking back, like if I wrote we were just talking to somebody that had a foot surgery. Seriously, I think they had one toe operated on. They left the office from the nurse. They didn't even ask for 120 Vicodin, a prescription for 120 Vicodin. And then they didn't even use it. They used some Tylenol, and their toe was fine. When I started practice 30 years ago in Lake Elsinore, if I seriously wrote a prescription for 120 Vicodin, I probably would have got a call from the pharmacist going, "What are you doing? I don't even think we have that much in our pharmacy." It's totally different now. And we have Chronic Pain Anonymous groups. I thought we were like the beginners in doing this, and we were. It turns out Chronic Pain Anonymous 12-step groups have been around for a long time. I'm powerless over my pain. And that's almost the time that, because a lot of people come in with a really, a point of view, a mental state that's not going to work. They're not going to make progress because they're more like, they're pissed off that they have pain. Why me? Why did God do this to me? And those doctors in the hospital, and this isn't fair. And eventually you got to get to the point where you accept the fact that you got pain. And then you can get into the solution. And another bit of interesting sideline was an angle that's happening is their pain is actually getting a reward for the opiates, especially if you have this addictive brain that has this real euphoric experience to taking an opiate. You have this pain, and actually the more pain you have, the more euphoric rush you can get off of it. Unconsciously, whether you're trying to do it or not, you have this pain, you're giving a little treat to your pain because you take this opiate. And you do that over the years, and you do this little dance for years and years. By the time you come into to treatment, part of your brain actually is frightened of letting go of the pain. It's been conditioned to be attracted to pain. It's a fun little dance, and we have to unwind that. So, hopefully the stigma is changing. We have examples like this guy. He was fun. Rush Limbaugh was bashing drug addicts like crazy and taking tons of OxyContin. And he blew out his hearing. Some people, if they take enough opiates, their hearing goes out. But now he's in recovery and yeah.
How is it that somebody like an athlete could take 80 tablets of OxyContin a day and not overdose?
He had a lot of years of building up to that, and I forget how many pounds and how tall he was, but he would.
70 pounds.
Yeah, if he walked into this room, you would go, "Wow!" Now I would not want to play football with that guy. I don't even want to be on the same field with him. It's impressive how big these guys are. So their metabolism rate is like huge. Yeah.
Is there opiate-induced emotional pain?
Yeah, because now that one crosses over to all the euphoric causing addictive drugs. Yeah, exactly. That's a pretty wild thing too. Anger, guilt, resentment, inferiority, unworthiness. Actually, if you didn't have those, addictive drugs don't really work that well. If you're really in a good mood, you have no fear, no anger, nothing to hide, no inferiority, no unworthiness, and stuff like that, and you take a bunch of opiates or any pill, drink, take some pills, it has a lot of side effects. You have to really be in a bad mood to have it work, and the worse mood you're in, the better kick it has. So every addict has that. They're conditioning themselves to be attracted to any negative emotion. All my addicts come in, yeah, They have like PhD in negative thinking. There's an unconscious attraction to negative thinking. Part of their brain is uncomfortable with positive thinking because of that, because they know the dance is over.
But does the opiate itself actually induce emotional pain?
No, it's a reward and it's a conditioning sort of response. But I see what you mean. Yeah, it's not like the physical.
Similar to what it would do with
rewiring the anatomy and physiology. Yeah, I don't know. Yeah.
Yeah, Dan, you mentioned the word recalibrate a bunch of times.
Yeah.
And when patients have come in chronic pain and you're switching them over to Subutex or Suboxone, you have to put them in withdrawals for 2 or 3 days before you start Suboxone, right? What I've noticed, and I think a lot of other people who are in this field have noticed, is that when you start the Suboxone, you recalibrate the pain experience, and low doses of Suboxone have as much or better effect than high doses of methadone.
Yeah.
Or Demerol, whatever it is that they're using.
Yeah.
And it's this recalibration effect. I don't think anyone really understands exactly what's happening, but that's in theory what's happening. Is that they recalibrate their pain threshold, and their experience of pain changes.
Yeah.
And unfortunately, I don't think, unless I could be wrong, but Suboxone still isn't approved for pain control, is it? It's just
I know.
It's just for opiate dependency.
Right.
But it has a pretty profound effect on controlling pain.
Yeah.
I think they're working on that.
Yeah.
But that recalibration thing is, that effect is pretty profound.
Yeah.
And by the way, one other comment, the way we talk about it, the way I talk about it, is that there's the pain and there's the suffering. You
Right.
take 2 people, give them the same pain.
Yeah.
The guy that suffers has infinitely more pain.
Yeah.
If you can reduce the suffering with yoga, meditation, transforming your life, spirituality,
Yeah.
etc., their experience of pain changes.
Yeah.
And so the pain itself is the physical aspect of pain is a different thing. I have a patient you're making me think of who is escalating her pain medication from a low back problem, but she feels bad about taking narcotics.
Right.
She feels, it's a failure in her life. And she's an addict, and I cannot telling her you're not an addict. You have bad pain.
Yeah.
But she's probably getting into this cycle of opiate-induced
All the quality of life
her quality of life
is going down. Yeah. Yeah.
Anyway.
Yeah. Okay, so I didn't really use my slides that much. I gave up. But yeah.
I just wanted to ask a question about Suboxone.
Okay.
Is Suboxone just usually intended for somebody to, when they detox off opiates, for just like 7 days to ease the withdrawal symptoms, and then off of the Suboxone too, because doesn't Suboxone have a withdrawal as well?
Yeah, you can get addicted to Suboxone or Subutex. We have people coming in. Usually that's when they're taking, there's either a 2 or 8 milligram. And we never use the 8 milligram because you're not going to accomplish much. You're not going to unwind the system on the 8s. You've got to start with the 2s and just get them off. And it really doesn't totally start to recalibrate until you get to 0 Subutex too. But yeah, I mean, the Suboxone actually is 2 different drugs too. There's a difference between Subutex and Suboxone. Subutex is just pure buprenorphine, which is a drug that actually partly acts like an opiate and acts like a non-opiate, an anti-opiate. And then Suboxone, which you use on an outpatient basis, has this Narcan-type chemical in it. If you inject it, you have immediate withdrawals. It's just a way to prevent it or decrease the amount of diversion, selling it to heroin addicts and stuff. It's supposed to be safer that way. So did I answer your question? No. Yeah.
What do you think about treatment programs that are prescribing long-term low-dose Suboxone?
Yeah, I think they're missing the point there. Your body, your nervous system doesn't really recalibrate until you hit 0 Subutex or 0 opiates. It's a partial opiate. It's 100 times better than methadone. My opinion is that really methadone should be outlawed. It should be off. And if you're considering maintenance, which I think some people benefit from methadone, and there's some studies showing that there's some people because the relapse rate is so bad with IV heroin use and stuff that they would be better off on an opiate, but it should be buprenorphine. because you can't overdose on it.
So you're saying that maintenance with Suboxone is appropriate in some settings?
I never do that. In fact,
For dependency,
yeah.
not necessarily for pain.
If that's the only choice, and if they aren't motivated in getting off their opiates, or they've had like years of close calls, near accidental overdoses, and they're trying to start and stop, and their motivation isn't that good. I've never really worked in a methadone clinic. I've never seen that, but apparently I read studies like there's some people that are on methadone maintenance that really do well, and I've seen a lot of people overdose on heroin and die. So it's better than that. But the reason why FDA approved buprenorphine fairly rapidly was France did a study, and they switched all these people off methadone and put them on Subutex and buprenorphine. Something like they calculated out that the overdose rate for 1 year was like 600 people less in the whole country, just because they switched people off methadone and put them on Subutex. So they saved like 600 lives that way. And so that's when the FDA said, wow, this is big. We need to approve this in the United States. It's really hard. I think it's impossible, almost impossible. Probably some of our addicts can push to the limits to anything, but it's pretty hard to overdose on Subutex. Okay, thanks a lot.